Hello, everyone, and thank you for joining us for this event presented during the 76th United Nations General Assembly. Our topic today is investing in surgical, obstetric, trauma, and anesthesia care to achieve the Sustainable Development Goals. This webinar is presented by the G4 Alliance, the Global Alliance for Surgical, Obstetric, Trauma, and Anesthesia Care, with the support of the Conrad N. Hilton Foundation. French and Spanish interpretations generously supported by Operation Smile and Smile Train. My name is Dan Peterson, Executive Director of the G4 Alliance, and I'm pleased to welcome you all here. You have the opportunity to participate actively in our event. Please put your questions in the Q&A, which will be visible along the bottom of your screen, and our moderator will get to as many of those as possible at the end of the panel. But you can also share your comments with all the attendees by putting them right into the chat, which is also visible at the bottom of your screen. I'd like to introduce our moderator for today. Professor Kathryn Chu is the inaugural director of the Center of Global Surgery at the Department of Global Health at Stellenbosch University. She studied at Stanford, at University of California, San Francisco, and at the London School of Hygiene and Tropical Medicine. Her research is focused on evidence-based solutions to improving high quality and timely surgical access in resource-limited settings. She's co-authored numerous publications and serves on a number of international and national advocacy groups in this area. She's committed to building a pipeline of future global surgery leaders through capacity building and mentorship. Please join me in welcoming our moderator, Kathryn Chu. Kathryn?
Thank you so much, Dan, and thank you to the G4 Alliance for this opportunity and to our other sponsors, including the Hilton Foundation and our other sponsors. I'm really delighted to be moderating this session. We have a fantastic panel ahead of us for the next hour. So without further ado, I think let's get started. Dan, can I have the next slide, please? So first of all, what is surgery, obstetric, trauma, and anesthesia care, or what we'll refer to as SOTA? So first of all, is SOTA important? Well, we think so, because it can address up to 1/3 of the global burden of disease. And SOTA is a cross-cutting health service that can address multiple points in a health system. So SOTA is essential to reducing morbidity and mortality at all stages of life. Therefore, their full development and integration into national health agendas is required. So SOTA has been recognized by the WHO and now the UN as key components to health system strengthening and achievement of the SDGs and UHC. So that's why we're here today, to discuss the relationship between SOTA and achieving the SDGs. So really, thank you for joining us today. We believe that excellence in SOTA care will translate into tremendous broader impact on the lives of individuals and communities. So for the next hour, our esteemed panel will delve more deeply into how SOTA can address some of these SDGs. Each panelist will speak for about 5 to 8 minutes, and then afterwards we'll have plenty of time to take questions from the audience. So I would first like to introduce our first speaker, Dr. Shingai Yagusei from Harare, Zimbabwe. Shingai, the floor is yours. Shingai, you may be on mute because we cannot hear you.
Oh, sorry. Yes. Thank you so much, Prof. And thank you to the G4 Alliance for this invitation to this, what I feel is a very important panel. So I'm a consultant anesthesiologist, currently stationed at Central Hospital in Harare, Zimbabwe, which is a low middle income country in the southern part of Africa. I'm a clinical doctor, but I have a passion for strengthening health systems, especially global surgery. I'm also a member of the SADC SOTA network, and I'm one of the focal points for our ENSOP here in Zimbabwe. I'm also a member of the AfroSurge Collaborative, which is collaboration of SADC and African clinicians and doctors, which is focused on creating African solutions for our own problems. Okay, so I can get started. So I'll first talk about SDG 8, which aims to promote sustained, inclusive, and sustainable economic growth and decent work. So in a country like Zimbabwe, with high levels of unemployment, there are many households who survive via the informal sector. And in a 2015 household study, the incidence of catastrophic health expenditure was 13.4% in the poorest quintile. And additionally, 1.29% of households fell into poverty due to health-related expenditures. And things like this then locked the community and indeed the nation into cycles of poverty and economic stagnation at a household and at a national level. So what does SOTA have to do with economic development, if anything? So the Global Surgery 2030 policy brief estimated that the GDP losses that are occurring as a result of depletion of the labor supply and capital stock due to untreated conditions. And they projected that LMICs will have projected losses estimated at 12.3 trillion between 2015 and 2030, unless there's urgent scale-up of surgical care. And this will translate to about 2% annual GDP, strictly from neglected surgical diseases. And this is a graph just to highlight the points I just made. And this then speaks to certain conditions, injury here in red. And you can see with each passing year, the losses, the projected losses are increasing. So the blue is neoplasms and so forth. Next slide, please. So, yeah, thank you. So, you know, surgical care is big. It's not one disease process. So is it cost effective? Lancet Commission on Global Surgery, as we all know, did extensive work into this and found that it is affordable. Investment in surgical services in LMICs is affordable, it saves lives, and it promotes economic growth. So scaling up to meet the target of 5,000 surgical procedures per 100,000 population, they estimate would require about 304 billion euro. But this needs to be countered with the potential lost output of 10.7 trillion euro if nothing is done. So this investment will help reduce the financial burden on individuals, which, as I mentioned in my previous slide, is very real. And also reduce the burden on communities and countries, and has a very real chance of breaking the vicious cycle of poverty that results from absent or poor surgical care. And the ripple effect, of course, on health-related industries will have a direct impact on SDG 8, from direct jobs at hospitals, you know, as theaters and wards start to run, to all the industries that supply drugs and sundries. The potential for decent work and proper income for the populations in LMICs is enormous. And I'm also going to speak on SDG 3, which is to ensure healthy lives and promote well-being for all at all ages. So you might wonder, how does SOTA ensure health, promote well-being? As Prof mentioned before, 28 to 32% of global burden of disease is amenable to surgical care. And surgery is crucial to ensure healthy lives at all stages. there are various approaches you can look at this at. If you look at a life course approach, from neonatal duodenal atresia, first few days of life, to cataracts in the elderly, surgery promotes well-being and prevents death. Just to make it more local, before COVID, our waiting times for pediatric hernias were reaching 18 months at one of our main pediatric surgery hospitals in Harare. And eventually, many of these children then present as emergencies, and of course, outcomes become poorer. If you approach this from a disease burden side, SOTA contributes to control of communicable diseases, such as in male circumcisions and also in NCDs, diabetes, etc., cancers. And from a level of care approach, SOTA is important both from prevention of disease to palliation of disease. And improved SOTA care will directly impact many of the SDG 3 targets. I won't go into them in detail because I'm sure we're all familiar. I'll just focus on 3.1, which is to reduce global maternal mortality ratio. And it will be very difficult to reduce maternal mortality without sustained and proper investment into SOTA, because this is cross-cutting from the theaters to supplies of blood, pharmacy, laboratory. Investment into SOTA will trickle down into maternal reductions in maternal mortality ratio. So next slide, please. Then I'd just like to tie it into ENSOPs. Everyone speaks about SOTA. We all know, we've seen the statistics, the papers, the evidence. It's irrefutable. However, it's been 6 years and old habits die hard. And one of those old habits is silo and programmatic funding. Surgical care is still too ambiguous, especially for some policymakers and even for some funders. And I would advocate that ENSOPs are a key step and tool to fine-tune all the things that we're talking about and give policymakers and funders a roadmap. And so I'd encourage, as we leave this seminar and webinar, to really look into how we can operationalize and create ENSOPs, support countries like Zimbabwe who are trying to develop ENSOPs to move the SOTA investment agenda forward. Thank you for your time.
Thank you so much, Shingai. And what a way to kick us off, starting out talking about how SOTA affects health and well-being, as well as economic productivity. Because, if we believe that SOTA care can address up to 1/3 of the global burden of disease, and many, many people around the world, I would say everyone needs their health and well-being to work but to lead productive lives. It is so important on the downstream impact of care. And I like how you tied it all back into ENSOPs. It's a National Surgical Planning. I see there's a question in the chat. Perhaps we can elaborate more on it later. I'd like to introduce our next speaker. It's Dr. Renzo Quinto. He wants to be called just Renzo, and I will let him introduce himself. Take it away, Renzo.
Thank you so much, Kathryn. And of course, thanks to the G4 Alliance for this wonderful opportunity. Renzo Quinto here. I'm speaking from the Philippines. It's 10 p.m. here in Manila. But again, it's a pleasure having this global conversation. I'm the inaugural director of the Planetary and Global Health Program here at the St. Luke's Medical Center College of Medicine. And also, very soon, I'll be assuming another role as Chief Planetary Health Scientist of a new Sunway Center for Planetary Health that we're establishing in Kuala Lumpur, Malaysia. And so, I'm coming from the planetary health and climate change perspective. I am not a surgeon, but I see my work as being a surgeon for the planet, trying to really address the planetary crisis that we are facing. So for the next several minutes, I'll be talking about how global surgery, from my perspective, should transform in this era of climate change and planetary health. Next slide, please. And you might be wondering, what is planetary health? Planetary health is a new powerful concept that brings together the health of the people and the health of the planet. We cannot anymore keep on treating patients on a sick planet. We cannot anymore ignore the myriad planetary crisis that we are facing now, biodiversity loss, desertification, ocean acidification, and most importantly, climate change. Next slide, please. And I will not belabor you with the details of this graph, but it shows to you that climate change impacts human health in many different ways. You will see multiple arrows representing the diverse pathways by which climate change affects health. And on your right, you will see that there is no single disease group that is immune to the effects of climate change, whether they are infectious diseases like vector-borne diseases, malaria, dengue, all the way to the chronic non-communicable diseases, heart disease, heat stroke when you get exposed to extreme heat, or undernutrition. We expect around 50 years worth of nutritional gains to be reversed if climate change will not be averted. And of course, there's a growing evidence of the impacts of climate change on mental health. Next slide. And very briefly, I come from a country that knows and sees and experiences climate change on a daily basis. It's not an issue for tomorrow. It's already an issue that we're confronting now. This is the map of Southeast Asia. And in this map, the redder the country is, the more vulnerable the country is to the climate crisis. And so as you can see, my country, the Philippines, is really at the heart of this planetary crisis. Next slide. And so you might be wondering, why are we discussing climate change in a panel on SOTA, surgery, obstetrics, trauma, care, and anesthesia? And actually, over the past several years, that there has been a growing conversation around the role of surgery, of surgeons, of operating rooms, in terms of addressing the climate crisis, and which you can see from all these headlines. And we know that climate action is SDG 13. Our session now is about the links between surgery and the SDGs. And I hope that the surgeons and the obstetricians and all the members of the SOTA community in this room or Zoom will not forget SDG 13 as you try to create the linkages between surgery and the SDGs. Next slide, please. So what are these myriad linkages between climate change and surgery? Of course, we know when climate change and extreme weather events, strong typhoons, intense flooding do occur, health services get disrupted. And part of these wide range of health services are surgical services. And in fact, surgical services are perhaps some of the most affected services when a hospital gets destroyed, an entire floor gets inundated, or electricity access gets disrupted. You can provide preventive care while your hospital is non-operational, but definitely not surgical services are very very much jeopardized in these kinds of situations. Next slide, please. And of course, SOTA inequities are still very pervasive in many parts of the world, including in my home country, the Philippines. The farmers and the fisher folks, they don't have ready access to available, affordable, and quality surgical services. Pregnant mothers, for example, especially in coastal areas, may find it very difficult to access good obstetric care, including cesarean section. And so, these are already communities already marginalized when it comes to accessing SOTA services. And climate change is going to worsen their existing vulnerabilities. Imagine the farmers who are not able to anymore harvest enough food. And that will result in limited income and therefore limited ability to access surgical services if they need them when they need them. Next slide, please. But of course, it's not just in terms of service disruption and worsening inequalities where climate change and surgery are very much interlinked. We know that healthcare services in general are also contributing to the climate crisis. The US healthcare system is actually contributing 10% of the whole nation's total greenhouse gas emissions. And there's actually a global estimate that 4.4% of the global greenhouse gas emissions are actually coming from the health sector. And of course, our operating rooms, our SOTA services are part of these healthcare systems, from the energy that we use, the waste that we produce, the food that we serve to our patients and staff alike, the transport system. So all of these are contributing to the emissions from healthcare. Next slide, please. And in fact, this is one review where they actually tried to calculate the greenhouse gas emissions coming from a wide range of health services. And the ones in the red box are the SOTA relevant services, the surgical procedures and the anesthetic gases, all of them also contributing to carbon emissions. So perhaps as a contribution of the field of surgery and obstetrics and anesthesia or anesthesiology to addressing the climate crisis, we might want to start thinking, how can we reduce our carbon emissions while we provide care and at the same time protecting our planet? Next slide, please. So there's actually one study that tried to identify what are the main sources of carbon emissions of an operating room or an operating theater. And as you can see, the supply chain in waste is pretty consistent across all three operating theaters. But depending on the operating theater, two of them actually are producing a lot of the GHGs, greenhouse gases, from the use of anesthesia. And there's one operating room where energy consumption is the major source of greenhouse gas emissions. And so these are things that we might want to consider if we want to decarbonize and lessen the contribution of surgery to the climate crisis. Next slide, please. And then I mentioned already anesthetics a while ago. So here are some graphs showing to you that some anesthetics have higher global warming potential, GWPs, meaning they are likely to increase the likelihood of continuous climate change. As you can see, the inhalational anesthetics are contributing a lot to this problem. And so this will probably be important to guide decisions among anesthetists or anesthesiologists in terms of which anesthetic to use for their patients that are also good for the climate. Next slide. So I would like to ask our community, are we ready to build surgical systems that consider the climate? And that it's in terms of reducing our emissions, but also enhancing our ability to address to the surgical and the SOTA inequities that climate change will exacerbate in the years and decades to come. Next slide, please. And so I invite the SOTA community to adopt this concept of climate smart healthcare. Climate smart healthcare means that a healthcare system is both able to mitigate climate change, reduce its emissions, adopt sustainability principles and practices, but at the same time, adapt to climate change, respond to the health consequences of the climate crisis, and enhance its own resilience so that not only our hospitals, but also our operating rooms do bend but don't break, that they are the last building or the last room standing. And so hopefully surgery will be central to this climate smart healthcare agenda. Next slide. And I had the privilege to co-write this report about decarbonizing the health sector. We published it in early 2021. And as you can see, that there are many things that we can do within healthcare to reduce our carbon footprint. Shifting to renewable energy, investing in green building design of hospitals, including the OR, lowering or incentivizing and the use of low carbon pharmaceuticals. I already mentioned about the anesthetics a while ago, implementing circular healthcare and sustainable healthcare waste management. So all of these are important actions for the health sector. And, I believe that a lot of these actions can start even at the level of the operating theater. Next. So that's it. Let's create a better world, a healthier people, and a healthier planet. And I invite the surgeons and the entire SOTA community to join us. Thank you very much.
Wow, thanks for that fantastic presentation, Renzo. And I think, I think it really puts the SOTA community into the larger kind of scheme of the planet. And I think that it also takes us out from what sometimes seems like a very narrow world. And I find it very interesting because on the one hand, we're trying to argue for scale up of SOTA services. And I think that was a really good time to think about some of your points about being greener. And if we have time later, I'm going to ask you a little bit about the fact that we are trying to decentralize surgical services. So bring surgical services closer to the community and how that will impact positively or negatively on climate change. But maybe we can get to that later. Okay, so next we were on to Dr. Lubna Samad. She's a pediatric surgeon from Pakistan, and I will let her introduce herself. Take it away, Lubna.
Thank you so much, Kathryn. I'm a pediatric surgeon working in Karachi, Pakistan, and I have been actively involved in global surgery health research as well as implementation for over a decade now. I'm going to try and stick to 3 short slides. I've really enjoyed the presentations before this. So this has really been a learning experience for all of us, including the panelists. What I'm going to be talking about is the SDG 1, which essentially aims to end poverty in all forms everywhere. And I think it's important for us to go back and look at the fact that in 1990, 36% of the world's population was living in extreme poverty. And in 2015, this decreased to 10%. And a lot of this effort is going to be reversed by the current COVID pandemic. So now more than ever, the focus on SDG 1 is very important for all of us, and in order to improve health systems, because poverty and health are inextricably linked. Next slide, please. I'm going to really talk about the data that we collected in Pakistan, and it's stark in reminding us how important it is to provide surgical care to our populations in a way that they can access it and which does not worsen their economic condition. So we looked at the Lancet indicators 5 and 6, and we interviewed to assess financial risk protection in Pakistan. And this was a nationwide survey done just before the start of the pandemic. We interviewed patients admitted in 13 tertiary public sector hospitals across the country. And the slide shows you, the map shows you that this was spread across all the 4 provinces of the country. A total of 526 patients were admitted, who were admitted for bellwether surgery were included in this survey. And the next slide, please. Could I have the next slide, please?
Dan, are you still controlling the slides? Lubna would like to have the next slide, please.
Thank you. So in this slide, I'm just going to show you the data that we got during the survey. And if you look at the catastrophic health expenditure, almost 80% of our patients had experienced catastrophic health expenditure in order to access just the basic bellwether surgery. So this was either a C-section, a laparotomy, or a fracture fixation, in which 79.5% faced catastrophic health expenditure. Similarly, over 70% of the patients faced impoverishment as a direct consequence of these surgical procedures. The patients are, so this, it is important to remember that the patients that we interviewed were admitted to free public sector hospitals. But despite that, they were spending $136 for the procedure as direct medical expenses, and more than that in non-medical expenses, which included transportation, as well as accommodation for the family, stay, food, etc., that they needed to buy in the city while they were staying there for surgical care. And the total cost amounted to over $300. And this obviously increased as we go from C-section to laparotomy to fracture fixation. Very importantly, 50% of our patients needed hardship financing. And the vast majority of this was loans taken. And as many of us are aware, loans taken at this time are often debilitating for families. They have to sell assets in order to return loans. They become encumbered with loans for life in many, many situations. Next slide, please. And startlingly, if we look at prior to surgery, if we look at the World Bank threshold, 53% of the people that we interviewed, these families were living below the poverty line. After surgery, and this is not even during the rehabilitation phase, we're talking about immediately after surgery, patients who were still admitted in the hospital. This percentage increased to 70%. 91 newly poor were added. As a friend of mine says, we've heard about the nouveau riche. This is the nouveau poor. People who became newly poor just because they had no option but to seek surgical care. So that really is my last slide. And I've used numbers to demonstrate the importance of surgical care provision, ensuring that it is accessible and actually free of cost, because the access challenges, the transportation fees, family members needing to travel in with the patient, place a burden on our population that is tipping them into poverty every single year. And to recover from this and to get back above the poverty threshold is far more than most of our population can achieve. So I think the importance of linking surgical care for improving surgical systems, for improving access to surgical care is critical in achieving SDG 1. Thank you.
Fantastic, Lumna. It's pretty sobering, though, that people who seek surgical care in hopes of improving their health and well-being end up pushing themselves farther down into the poverty, below the poverty line. And perhaps if we get more time, we can talk about maybe some potential solutions to that, because I would hope that SOTA care would actually bring people out of poverty, but instead your study has shown the opposite. And I think similarly in South Africa, we also at public hospitals, also care was free, but all the reasons you mentioned, transport costs, family costs, ended up making them poor. Okay, on to our next speaker, last but not least, Associate Professor Salome Masimwe. Salome, will let you introduce yourself. Take it away.
Thank you so much. And again, thank you as well for inviting me. I'm Salome Masimwe. I'm an associate professor at the University of Cape Town, and I'm also an obstetrician and gynecologist. I'll be talking about two SDGs, and which link up well with especially with the previous talk. Next slide. So does it really matter where you live? And so I'll be looking into sustainable cities, inclusive, safe, and resilient cities. And so the picture that you get is a lot of people, especially in low and middle income countries, who are living in rural areas, who decide to migrate to the cities, hoping that they're gonna find good jobs, make a living for themselves, and live probably in the house that you see there. But a lot of them end up living in urban slums. And so what you're starting to see across the world is a lot of people that are, or a lot of the population living in urban slums. And so a lot of work into creating sustainable and inclusive cities has really become important. And it really matters to us as the global surgery community and as the SOTA community. Next slide. And so my interaction has been looking at healthy cities, and so interacting with architects, town planners, engineers, and looking at the interface between global surgery and infrastructure. And so some of the groups that have worked on this kind of work in South Africa is the African Center for Cities at UCT. In UKZN, they've got a center for inclusive cities, and at UCT, they are also forming a center for infrastructure justice. And you can't talk about all of this without looking at it from a healthcare lens. And so from a healthy cities perspective, it's really about creating a health supportive environment, ensuring that there's access to healthcare, looking at the well-being of communities, simple things like, are there parks for children to play? Whereas in urban slums, for example, no one is looking at that and creating spaces, inclusive spaces for recreation and well-being, and looking at issues around quality of life. We all know that the health-related solutions, which are often what people look at when they're designing inclusive cities, will look at issues such as food, water, sanitation, access to housing, reducing emissions, north-facing houses, green building technologies, and also recreational and wellness spaces. And so all of these end up being a part of the social determinants of healthcare and social determinants of surgical care. So we can't really talk about global surgery without thinking about infrastructure and the spaces that we live in. Next slide. And so a case study that I'm going to give you, an example that I'll give is accident reduction and looking at injuries and trauma. And so injuries, as we all know, is a neglected epidemic in LMICs. More than 90% of injuries related deaths occur in LMICs where preventative measures are non-existent and health systems are least prepared. Accidents cannot be blamed on humans alone, but they reflect the interaction between the human being and their environment. And so the built environment also needs to get involved in discussions around injury and injury prevention. Accidents lead to preventable deaths. So you can have, it's not just that you had an accident, it's where your accident happened, that where the means in place to prevent your death, to prevent hospitalization, to prevent permanent disability and loss of income. And so as you've seen and heard from other speakers as well, that the trauma may happen, we want to prevent it, but it may happen, but it's the access to care that you have where it happens. So paying attention to geographical locations, to the cities, to designing how they're designed and how they respond to injuries and trauma is an important part of the work that we do as well. And measures to reduce fatalities from injuries and accident reduction policies that should include traffic control planning, pavement standards, planning for fire stations, standards for playground equipment, speed bumps, roundabouts, etc. So, and the point that I want to make is, much as it's not, we often just look at what we are going to offer the patient that ends up with us, but there's a lot more that's involved in it, and we need to think beyond just what we can do inside the hospital and on the scene of an accident, and look broadly at what can be done to make the city safer and more inclusive and create a better environment for the patients and the people that we see. The next slide, I'm going to move quickly to Sustainable Development Goal 5. And this, I've based my few words and comments on the Lancet Commission on Women and Health. Women merit special attention because of their distinctive contribution to society, a contribution that is often under-recognized, undervalued economically, socially, politically, and culturally. So we know that African women are 50 times more likely to die from cesarean section complications than women in high-income countries. More than 1.4 million women receive a diagnosis of breast cancer every year. We know that cervical cancer is a leading cancer in the world, and 80% of these deaths occur in LMICs. Over 2 million women live with untreated obstetric fistula in Asia and sub-Saharan Africa, and approximately 3 million girls undergo female genital mutilation every year. And so I'm raising these numbers just to show the awareness, to give you an awareness of what happens and what are the women's surgical outcomes. Much as we respect that women merit special attention and have an important role in society, the fact that we are not eradicating some of these preventable diseases is borders more on a human rights issue. And as when you look at something like female genital mutilation, which there is absolutely no medical indication for it, but it continues to happen, particularly in LMICs and specific countries that have not decided to see it as a human rights issue. So in closing, I'd like to go to my next slide and to quote the words of Professor Mahmoud Fatala, who boldly said that women are not dying because of diseases we cannot treat. They are dying because societies have yet to make the decision that their lives are worth saving. So it is a gender equality issue at the end of the day. We can quote the numbers, the stats, but ultimately to improve women's health and women's surgical outcomes, we have to look at it through a gender equality lens. Thank you very much.
Wow, thanks, Salome. Really powerful words. And I think that the first part about healthy cities and the social determinants of health really is very relevant here in South Africa. Here in Cape Town, even we have our informal settlements in areas of which have a lot of gangs, and the ambulances can't go into certain areas without a police escort. So they call those red zones. So, for example, if a person is shot in the chest, every minute is important to save their life, but the ambulances have to first go to the police station and wait there because of the insecurities in that area. And sometimes they wait for 3 hours before they can go then to pick up the patient. And by then, as we know, it's a little bit too late. So yeah, wonderful. So I just want to remind everybody in the audience, please feel free to post any questions in the Q&A. I see that there are a few questions there. There was one question posted just to the host and panelists, but I'd like to ask Dr. Lubna this question. It's from Anip Joshi, and it was about how do you get started writing or developing an NSOAP? And I think that many people express that frustration in different countries about NSOAPs and how do you get buy-in. So perhaps maybe just to start with that. Lubna, do you want to take a stab at that one?
Kathryn, thank you. I think I'm well placed to comment on that because we really struggled to get our national surgical plan up and running with an 18-month hiatus for the pandemic. So, I think the key initial step is stakeholder engagement. It is so important to get the people who matter convinced, to get them on board. What we found practically is that when we talk about surgery in the global health arena or a national surgical plan, most of our ministries, our finance ministry, our health ministry are completely oblivious to this term. So we really have to start by introducing the term. Although our governments may well have signed the WHO resolution 68.15, when we talk about the implementers or the policymakers within governments, there is an absolute inability to understand where surgery sits within the public health or the global health agenda. So convincing the powers that be in the capitals and in the ministries is important. And similarly, for me, I thought it was the most exciting part was getting my surgical colleagues to understand that they could shape surgical systems policy planning for the country. So, going from city to city, from province to province, and getting the surgical community on board and seeing the dramatic difference in their attitudes during the course of a workshop was very rewarding, actually. So we used our professional societies, Society of Surgeons, Society of Anesthesiologists, pediatric surgeons, orthopedics, as platforms in which we used to engage our own colleagues into this wider dialogue. And then putting this the surgeons and the ministries and the policymakers in one room and starting the conversation. I believe that is the most important way to get started. Everything else falls into place, but I think getting the right people engaged and then just not giving up. These probably are the two things that work most for us, because unlike many countries, our NSOP was not started by the top level, by the government. We kind of started midway with the surgical community making a push for it, with a lot of help from the international surgical community. So I think that connecting the dots really was important in our case. I hope that answers some of your questions, but again, this is such a lot of learning over the past 3 years that I could go on for a bit.
Thanks, Lumna. And I think that putting SOTA in the larger context of planetary health, maybe then we'll get our politicians to listen. And I think there's a couple questions in the chat around the planetary health and climate change. So the first I'm going to address to Shingai. So there's questions about specific anesthetic agents and perhaps even reusing equipment, which might decrease carbon emissions. And Shingai, I know that this, hopefully not to put you on the spot about specific types of anesthesia, but we do know that our work in the operating theater is very greenhouse gas heavy, and we use a lot of equipment, we use a lot of energy. And I don't know if you have any thoughts, Shingai, around how we could start minimizing that as we go forward. How can we become greener?
I think as one of Renzo's slides showed, I think generally desflurane is one of the more carbon footprint heavy, so to speak, of our anesthetic gases. But again, a lot of LMICs, I think, don't really use it that much because of also the vaporizers that are required. But like you said, there's a lot of our equipment is very electricity wise. It's also quite consuming. So I would say one thing we have a huge resource of, especially in this side of the world, is solar. And I don't think we've really tapped into it or really thought about, because for my hospital, we've got electricity, then we've got a massive generator. So those, nobody's even thought about solar or how that can play into things. I think, and that's solar is now solar equipment is now quite out there. The easy to install. All the technology is out there, but nobody's actually taking that next step to actually install it into the hospitals. So I'd say, yeah, that's one easy and doable step that we can take as a sort of community to reduce our carbon footprint, and that's renewable energy.
Yeah, thanks for that. I really appreciate you bringing up renewable energy. And also probably just to point out that currently, I think most of the contribution to greenhouse gas emissions is from the high income countries. As you say, the low LMICs have a lower footprint, but as we want to scale up, now is a good time to be thinking about how could we do it better than other countries. Renzo, I'm going to ask you the next question. It kind of links to this, but there was a question in the Q&A, or maybe it was in the chat, about how can SOTA, affiliated climate change, greenhouse gas emissions be reduced overall. I think you addressed some of that in your talk, and Shingai's mentioned something else, but perhaps you could elaborate a bit more on that.
I think there's a great opportunity in coming up with climate smart, climate resilient, and low carbon NSOPs. And so if that is something that we can actually collaborate on, so the SOTA community and the climate and health community, to make sure that when this next generation of NSOPs are created in many low and middle income countries, that climate change is actually taken into account. I think that will be quite transformational. And I think that future climate smart NSOP should have a very clear plan as to where we are getting the energy from for our future operating theaters. How are we making sure that surgical services don't get disrupted when there's a hurricane or an intense flooding or some other calamity that is related to climate change? But I think we have not seen that kind of ENSOP yet, and so I think that's a great opportunity. I think it will be great if our medical education, health professions education in general, but also surgical, obstetric, trauma care, and anesthesiology education will actually begin to incorporate climate and health components. And maybe the slides that I showed to you are being seen by some of us in the room for the first time. I think we need to disseminate such knowledge more. And I think finally, there's a great opportunity for more research and collaborative research. I would love to see more surgeons and anesthesiologists working closely with climate scientists, environmental health experts to find solutions that will decarbonize the operating room while at the same time ensuring that there's access to surgery for everyone, everywhere.
Thanks, Renzo. The next question is for Salome. There's a question in the chat around certain cultures of sort of the culture of health endangering behavior contributing to high trauma stats. The specific question is domestic violence is increasing, at least in his particular community. And that sort of addresses both of the two SDGs that you had brought up, sort of gender issues as well as communities and social determinants of health. Salome?
Thank you. I want to agree completely with what has been asked, that culture and context are very important. And so the one thing that we often miss, especially as academics in this area, is including community engagement as a core component of what we do, because we can change the policies, we can change the frameworks and guidelines, we can provide more resources, but if you don't tackle the behavior and the way people do things and the buy-in from the community, you keep seeing the same patients over and over again. I liked what one of my MSc students said in a discussion around this, and she was working in a hospital where they kept dealing with patients who had knife stabs. And she says, it was a small community, so we knew who was stabbing who, we knew people will keep coming. And each time as doctors, we kept treating the patients that were stabbed and managing them, but no one looked at the knife and where the knife was coming from and taking away that knife. And that was just something very practical to say, we need to look beyond how do we manage the patient, how do we provide the surgeries, but how do we stop these injuries and change the culture and change behaviors that are going to result in more patients coming to us. So I think community engagement is an important aspect of SOTA that we all need to start looking into and getting involved in.
Thanks. No, that's fantastic. And I think that kind of speaks to I think some of you know that my big kind of passion is decentralizing SOTA care, and the WHO says that district hospitals should sort of be the focal point of essential and emergency surgical care. And at the moment, at least in sub-Saharan Africa, it's mostly the bigger hospitals, the central and the regional hospitals that are providing a lot of that care. And maybe I'll first start with Lubna in terms of trying to reduce the financial catastrophe, the catastrophic health expenditures. Do you see that perhaps bringing care closer to the community might help address that? And then next, I'm going to ask Renzo, do you think that bringing care closer to the community could address both the resilience, if there is a major natural disaster, about getting the access to getting care, and then perhaps the impact on climate change? So I'll start there. First, Lubna.
So I think recognizing that accessing basic surgical care can tip people into poverty is very important. Once we recognize that, we understand that one of the biggest issues is when surgical care is not available closer to home and people have to travel long distances, it not only delays surgery and affects morbidity and mortality, but when they go into the city, it's at great cost. We also have to remember that the people that we are looking at in the cities, in the big tertiary hospitals, are the ones who've actually managed to make it there. So this is a selected group of people who were able to overcome huge barriers at every step and actually arrive for care. And then they're going to have to handle their descent into poverty as a consequence. But that's for another day for them to take up. What we really need to do is to ensure that we improve surgical services closer to home in the public sector. This is just very important. There has to be a way to make sure that a woman can go and get a cesarean section within 2 hours of where she lives, does not have to travel. 50% of the patients in our study, for example, came from outside the city that they were interviewed in. So they traveled long distances to come in. And that's where the clock starts ticking, where the costs start going up. So it's important to, so we've been focusing on the first level of care in Pakistan as the emphasis for improving surgical care. We have district level hospitals or what we call here taluka hospitals, where smaller communities can have essential surgical care closer to home, and it is provided by the government sector in a systematically strengthened way so as not to put insurmountable obstacles in their way. It's really a matter of you should be able to get into a public transport or just rent out a taxi, travel half an hour and get the surgical care that you need without it having to be a 6-8 hour journey at prohibitive expenses to achieve that goal.
Great, thank you. And then Renzo, impact on planetary health, if we could get surgical services closer to the community.
Sure. I think the agenda around decentralizing surgical systems is very compatible with the agenda of building climate resilient health systems that are within the reach of communities. We know that a lot of the communities in the rural areas, in the coastlines, they're already experiencing climate change. And oftentimes the health systems in these areas are perhaps the under-equipped, undersupplied. And so there's actually quite a convergence there. If we want to build surgical systems close to people, then let's make sure that these health systems and surgical systems are also ready to combat the health effects of climate change. And if you're concerned about the carbon footprint of a decentralized health system, surgical system, that means we need the health system to be powered not by centralized fossil fuel coal plants, but by decentralized clean renewable energy. Solar was already mentioned a while ago. And so, these agendas are very compatible. We need to come together and find, synergies. And as you know, COP26, the climate negotiations is happening in November. I would love to see more surgeons in the negotiations calling for a healthy people and a healthy planet.
Thanks, Renzo. So I think we just have about 2 minutes left. I'm going to ask Salome a question about, is decentralized care going to be helping address some of those social determinants of health? And then Shingai, while I'm asking her, maybe you can think about, I know you guys just did a big survey in Zimbabwe about surgical capacity, mostly at the district hospitals, and perhaps Shingai, you can tell us what maybe some of the barriers, if there are any, of what's happening at the district hospital in terms of SOTA care. Okay, Salome, go ahead.
Right. So decentralized care, it goes with no doubt for me. It's important, but we need to look at healthcare in a system. Where I come from, at least the province that I come from, one of the issues is there are district hospitals everywhere. There are lots of district hospitals, but that doesn't mean that the patients who are critically ill, who need the highest level of care, are able to get this care. Often they have to be sent to another province at times to get the care that they need, because they are able to get, the hospital is an entry port into the system, but a lot of lives are lost because once they are in, it's getting into an ambulance that's going to take you 300 kilometers down the line with all the delays that are involved. So I feel the model that we need to improve is how do we strengthen the entire system, and looking at from your injury to getting into the district hospital, get the best level of care you can get there, But when you need a specialist, the specialist needs to be accessible, and there need to be multiple entry points for a person to receive the highest level of care within a system. So,
Thank you. And then last point from Shingai, from your hospital survey that you did for your NSOAP, can you speak to any of the issues that Salome is talking about, maybe some of the barriers there?
Okay, I'm just going to address Anib's question in the chat before we disappear, because I feel like they're probably at the same place I was, because it's to all the experts how to introduce NSOAP in a system which is overwhelmed with other healthcare issues. I think as Lubna kind of alluded to, be prepared to go for the long haul, be prepared to knock on a lot of doors. Try and identify 2 or 3 people who have some kind of influence, who might, who will be able to listen to your cause and take you into some arenas. But don't give up, keep pushing. All you need is one door, and one door will eventually open. And then, in terms of barriers from our survey that we did, one of the biggest issues we found was healthcare workers, manpower. Because at the provincial level, we're beginning to get, in Zimbabwe anyway, we're beginning to get more specialized surgeons. But one of our main issues is actually anesthesiologists. And countrywide, one of our anesthesia is a big issue. Anesthesia providers is a big issue for us. We're having a lot of brain drain. So the manpower issue was one big problem, a barrier to scaling up. Then the next biggest barrier for us was the drugs, the pharmaceuticals, supplies to the district areas. It's very erratic, and our pharmacy ordering systems are not that strong. So our main barriers were the manpower, the pharmacy, and our equipment is quite old. But I think we've actually had a bit of a break with the COVID. Suddenly, people in the country, policymakers know that there is a thing called an anesthesiologist, and they're actually quite useful. So we are planning to, get on that. We managed to get on the ICU side. They now know what ICU is. So we're planning to, make use of that eye-opening event of COVID to push further.
Thank you very much, Shingai. So I think we're out of time, but I just want to say thank you on behalf of the G4 Alliance from our fantastic panel today. Really appreciate all your comments, and I, for one, learned a lot. Yeah, and hopefully everybody will attend tomorrow's session as well. And I'm turning it back over to Dan to tell us more about that one.
Thank you very much, Professor Chu. Thank you so much for moderating such a wonderful discussion. And thank you to all of our panel members for joining us. Thank you all in the audience for joining us. If this has whet your appetite, if you're eager for more, please join us tomorrow as we continue this discussion on the social media platform Clubhouse, in the Global Surgery Club on Clubhouse. And if you're not yet a member of Clubhouse, you can join for free. Go to the G4 Alliance website on SOTA Online, on the G4 Alliance website, and you can see very detailed instructions there about how to join Clubhouse for the discussion tomorrow at 1400 GMT, 10 a.m. Eastern Time, for continuing this discussion on investing in surgical, obstetric, trauma, and anesthesia care to achieve the Sustainable Development Goals. Recordings of this event today will be available English, Spanish, and French on the G4 Alliance website on SOTA Online. So take a look there. You can see that recording there. Distribute it to your friends and colleagues. On behalf of the 62 member organizations of the G4 Alliance, thank you so much for joining us for this discussion, and we look forward to partnering with you further as we work on investing in surgical, obstetric, trauma, and anesthesia care to address the sustainable development goals. Thank you very much, everyone.
Thank you.
Thank you, Dan. Thank you, everybody.
Thank you.
Thank you
Good
very
night.
much. Bye.
Thank you, everyone. Great presentations.
Thanks, Laura.
That was fabulous. It was hard to keep up. You all had so much rich content.
Dan, you've
forward to
done a
watching
great job of keeping us all online. You've gotten us organized and on time. Thank you so much for doing that.
You're welcome. In fact, those that are remaining, I've gone ahead and promoted everyone who's still on to a panelist. So if anyone's still on, you now have the microphone. You're welcome to talk with our panel. If anyone has a question, I've put everyone in as panelists now.
Thanks.
I think everyone's in a rush to get done for the day.
Yeah, thank you.
It's very late for Renzo, at least. It's well
It's
past.
It's okay.
I'm
For
sure.
people in planet, I'm willing to stay awake.
What time is it?
Sorry?
What time is it?
It's 11 p.m.
Okay.
Exactly 12 hours apart from New York. Yep.
Oh.
But we should make that.
I've seen Renzo speak at 2 a.m. and he was fabulous. So.
Thank you. Yeah, but we should
Very
make
wide
those.
awake.
But we should make those climate smart ENSOPs. I think that is a very, very
Yeah,
exciting project to work on.
Yeah.
I agree.
And Labna, would you mind posting the study on our email, if you don't mind? Your study that you
Could, except it has just been submitted for publication.
Oh,
So
right. Okay.
This is
Okay.
new
Preprint.
data. It's actually submitted for publication
Oh, perfect. All right.
2 days
Oh,
ago.
well,
2 days ago.
we'll keep our eyes.
Oh, wow.
Yeah, I will definitely share it with the community then. Thank
All
you
right.
so much, everyone. Take care.
All
Bye-bye.
right.
Everyone.
Thank you.
Bye.
Okay.
Thanks all.
Bye.
Good to see everyone. Have a great day, evening.
Thanks, everyone. Thank you for joining us.
Well done.
Thank you again to
Great.
our interpreters, Anna and Natalie. Thank you
Yes.
so much. Another wonderful interpretation together. Thank you.
Merci beaucoup. Muchas gracias.
Oh, gracias.
I try to go back and forth among them, and they're all fabulous.
That's the best way to listen.
I did the same. I listened to all the interpretations as well as the presentation. So it got transposed at one point. The French was on the English channel and vice versa.
Yes, I think that did happen, but
It made it more
that was
more
a little
fun to jump
test, Jimmy, to see if everyone was paying attention.
Exactly.
That's right.
So anyway, thanks to everyone. It was
Thank you.
fantastic. This far exceeded my expectations. This was really well done and exactly what was perfect for the UNGA launch. So I'm sorry I won't be able to join tomorrow, but this was really worth attending. And I usually get distracted during these and try to multitask, but I have to say I did not leave the presentation during the entire 4 presenters and moderator. They were terrific.
Yeah, I had the same reaction, Jimmy. I did a little Twitter coverage, which you'll see, but other than that, I really remained focused, which is great.
Well done. Anyway, well done, everyone. Thanks very much.
Thanks all. Bye-bye.
Bye.
Okay, we'll close things down here. Thank you all for joining us on behalf of the G4 Alliance. We really appreciate you taking the time to join us today. Bye-bye.